How's how's it going, friend?
I'm good, Charmaine. I've been on a pretty busy teaching team. In fact, my resident actually joined, Laura, who's joined us to see me discuss live. So I'm under a little bit of pressure because if I don't do well now, she's not going to take me seriously during rounds.
Well, Laura, welcome, welcome. And I'm sure you're gonna do wonderful, Jazz. I have no doubts. Uh, and Kiara, we're so lucky that you're presenting a case.
Hi, Sharmin Jas. I'm so happy to be here. Yeah, I'm presenting a case. It's been a while, but I'm very happy.
I know I'm so excited to see you, friend. It's been a while, and I can't wait to discuss not cases, not cases for today. Maybe just one case.
One. Okay.
All right. Well, if you can get the board out, thank you so much for helping
Charm
out with subscribing and teaching points.
Charmaine, I think Mariana needs to be co-host. She's going to take over
Oh,
for.
you're the host. Do you want to make her co-host?
I was trying to, but I don't think I can.
Oh, okay. Let me try. Uh, Did it, Marianne, do you want to try? Did it work? Wonderful. Awesome, awesome. Thanks all. So Kiara, we're ready for you.
Yeah, absolutely. Um, so I think I'm going to start with the chief complaint and the whole HPI to save some time. So the chief complaint was abdominal pain and distension. And this HPI starts with a 61-year-old male who has not known past medical history, who presents to the ED over the night. He had 2 weeks of worsening progressive abdominal pain, and some associated symptoms were nausea and shortness of breath. And in the ED, his vitals were noted to be blood pressure 90s over 70s, a heart rate in the over the 100s, but otherwise the rest of his vitals were normal. He was already well on VMR, and he basically received a normal saline bolus, and he was hospitalized. A little bit more of his past medical history, basically none. He doesn't take any meds. He just had a brother with colon cancer, and social history denies alcohol, tobacco, or drugs. And for health-related behaviors, he was divorced, and he has a new female partner and denies any allergies. So that will be the end of the first aliquot.
Awesome. Thank you so much, Kira. First of all, just a huge shout out to you, Kira, for presenting a case, especially what's going on in Florida. I'm glad you're safe, and it really means a lot to us that you still made time to present this case. First and foremost, I think what strikes for me is like not missing an emergency here, especially considering this patient has been having seems like a pretty quick onset, 2 days of worsening abdominal pain and distension, with that vitals that we see. So the patient is tachycardic and hypotensive. Now it seems like he does not have any past medical history, so I would assume that his blood pressure was normal prior to this. So I think in this situation, I would be thinking before. I would be treating before I would be thinking. So I would give boluses. I would see if the patient has any evidence of sepsis or hemorrhagic shock. So I would actually be triaging this patient pretty urgently. Even if the patient is on room air and statting well, I think this is a patient that would be concerned that would be decompensating fast. But because this is a morning report and we do have the time to pause and think, the first thing I would say is that when I think of distension, I really want to break it down into three entities. Is this gas, liquid, solid? And what I mean by that is solid is your organomegaly. Okay, so hepatomegaly, splenomegaly, an expanding malignancy. Um, some patients can have a chronically distended belly due to adiposity. So, those are the initial things I'm thinking about solid. Liquid, okay, is this patient having an ascites? what clue we're getting so far that this might be decompensated cirrhosis is the low blood pressure. Remember, decompensated cirrhosis should never have a high blood pressure, or it usually presents with a low blood pressure. So could this be ascites leading to this? Was there any history of trauma, or did the patient have any type of evidence of urinary trauma to the belly that meant this may be urinary retention that may have now led to urinary perforation, urinary bladder perforation? Or, like, hopefully not, but is this a case of hemoperitoneum? You know, we don't, this guy's 61 years old and doesn't have a past medical history. Either that's true, or he hasn't seen a physician in a long time. And he had a hepatocellular carcinoma that now ruptured, and now we're dealing with hemoperitoneum. Gas is the last one, and that's the one that can be scary, or something totally benign. Something that's benign and more common is just bloating from having, for me, having too much dairy products. So for other things that I don't want to miss is ileus, okay, and then obstruction that may have led to a perforation. So overall, I'm concerned, before I pass it to Sharmin, I'm concerned for something that I would rather treat before I think. But while we're stabilizing the patient, I will be breaking it down into what is causing this distension. Is it a solid? Is it a liquid? Or is it gas? And given the acute onset, I would probably put more emphasis on the liquid or gas. Sharmin?
Ah, I can listen to you discuss cases all day, my friend. That was awesome. I totally agree with you. I'm worried about this patient. Sounds like we have a gentleman with no significant history that we are aware of that is coming in with 2 weeks of worsening abdominal pain, distension, shortness of breath, found to be hypotensive and tachycardic so far. And yeah, I think when it comes to figuring out if I'm like triaging this patient, as you mentioned, what worries me is that blood pressure, because yes, as you mentioned, like I don't expect a 61-year-old person to live in the 90s. Um, and the other thing that is just worth notable, what does that no past medical history mean? It doesn't mean this patient, as you were alluding to, Jazz, like doesn't have underlying liver disease or cardiac disease. So being very open into like any organ could be at play. And I think for this patient, the interplay between like the thorax and the abdomen is the one that I'd be keeping a close eye on, right? Because he's short of breath and has abdominal pain and distension. And the question is like where the main pathology lies. Is it cardiac in nature and it's presenting as abdominal pain, or vice versa? Is it the abdominal distension that is pushing on the lungs and making him short of breath? The one thing that I'm just like making a note of, and the reason why I'm like just thinking about the thorax and cardiac etiologies is that 80s over 70s, that the pulse pressure is something that I'm going to monitor very closely. The lower the pulse pressure, the more concerned I've become if that is something cardiac going on, and the wider it is, the more worry I will be for like hemorrhagic or distributive. And in terms of like what are your no misdiagnoses, again, like I think as Jazz mentioned, thinking about, you know, we love our white bone mnemonic. I think that covers a lot of the vascular pathologies, the itises, perforation and obstruction, especially with the distension. And the pain that he's experiencing, I think is a good place to start. However, just thinking about the neighbor of the abdomen too, and this is where like the exam would be very helpful if there's any significant like evidence of volume overload that would be informative, where the pain is would be really helpful. So yeah, in summary, I am worried about this patient, like getting your basic set of labs, repeating the vital signs, your ECGs, and working this patient relatively acutely. It's kind of where my head is at. All right, Kiara, back to you.
Oh my God. Okay, the discussion so far is amazing. And so there are three more remaining aliquots. The second one is basically vitals, further history, and physical exam. So you are both right. So I met this patient on his first day of his hospitalization. And when I met him, his vitals were, his pulse was in the 90s, his blood pressure was a little bit more stable in the 100s over 70s, respiratory rate in the 20s, and temperature 36 or 96 Fahrenheit. So I obtained some further history, and the patient hasn't followed a primary care physician in more than 10 years. And his symptoms started not 2 weeks ago, but 3 months ago. And those symptoms included abdominal pain, cramping, distension. He also was very weak. He had shortness of breath. He started developing lower extremity edema, decreasing appetite. He lost like 30 to 40 pounds in these months. And he also experienced like watery diarrhea with some mucus, he said. He tried Imodium, and that somehow helped, but not entirely. For the physical exam, he was cachectic, ill-appearing. He was basically anosarca. For HENT, was normal. His eyes were also perla. Cardiovascular, pulmonary, and neurological exam were normal too. So for GI exam, his abdomen was firm. There was kind of protuberant abdomen and severe distension. And it was also somehow painful on palpation, but there was no rebound. I could palpate a non-mobile gastric abdominal mass there. And for MSK, he had 3+ lower extremity edema.
Is this a good place to start, Kiara?
Oh,
Oh,
I'm sorry.
wonderful.
Yeah, that's the end. Sorry.
Okay, wonderful. No, this is such a rich case. Maybe I'll reflect on the additional information from the HPA and then leave the rest to the amazing Jess to discuss. So now, and then thank you so much for going back and like getting more history. And I think like especially when patients come in as they're sick, sometimes like it's hard to get all the details. And the beauty of it is like we can always go back and shed more light in what the patient has been experiencing. So Kiara, kudos to you for repeating those history. And kind of the history that you got kind of paints the picture of like someone who's like progressively over the last few months has been declining with worsening symptoms. And the most notable thing that I got with like the lower extremity, the distension, if in my mind, I am translating to that in like evidence of like volume overload, and the always question becomes like where that volume is coming from. And our first pass, oftentimes the three organs we think about are the cardiac, liver, and kidneys. And in terms of like the exam, clues that are helpful, like we know with elevated JVP often clues you into the heart. If there's any evidence of cirrhosis on exam in the form of like elevated estrogen, right, like your pulmonary arrhythmia, telangiectasia, scancomastia, oftentimes clues you if there's a liver at play. And then the kidney causes tends to be more silent on exam. However, oftentimes you see more evidence of anosarca. The other thing, to worth noting in someone who is also endorsing some diarrhea is any protein losing enteropathies oftentimes can cause a volume overload because of the low albumin in the blood. So uh, like those are the things that are jumping out to me as things that I would want to investigate. The other thing that is interesting is a dichotomy of like the weight loss in addition to evidence of volume overload. Is this patient is losing muscle mass while gaining some water, which again can provoke any of our favorite like inflammatory or malignancy etiologies as well. But I think my first step is to get a better sense of the foreground for this patient, making sure we're not missing any uh, devastating causes of like abdominal pain that need to be addressed quickly while peeling the onion back and see what we find. Jazz, what are your thoughts?
That was amazing, Sharmin. I typically cry a lot when I peel back onions, so let's see if I can pick another analogy. But so I think for first and foremost, let's take a step. Like I want to take a step back and kind of just ask myself, can a patient with progressive cirrhosis or progressive heart failure lead to anasarca? And it's not your typical illness script. You can think about it. If the patient if the patient has not seen a physician and they are slowly developing heart failure, they can become cachectic. But I agree with Sharmin that there's signals in this initial history that points to a more sinister diagnosis. And I was also thinking about protein losing enteropathy with the diarrhea. And Kiara, when we hear from your next aliquot, I'd be curious to see, how much diarrhea that was, and was it like just intermittent or was it chronic? Because usually protein losing enteropathy, it is usually a long course of diarrhea.
It was
But I,
chronic.
oh, sorry.
Yeah, it was chronic.
It was chronic. Okay, thank you. So that heightens the protein losing enteropathy hypothesis a little bit further. But I think when looking at this physical exam, I ask myself, why does this not fit with cirrhosis? Well, for one, the exam does not show any physical exam findings of cirrhosis. Patient is not jaundiced. There is no, pulmonary erythema, no splenor angiomas. So that would make me feel that cirrhosis is a little bit less on the differential. Why? And I agree with Sharmin that nephrotic syndrome can also sneak up with no physical exam findings. And if it's especially caused by like an adenocarcinoma, and you can have a cachectic appearing individual and lead to the anasarca. However, I would have expected the blood pressure to be a little bit higher than it was initially, but I don't want to put too much weight on it. But that would makes me feel like maybe perhaps that nephrotic syndrome might be a little bit less likely, but I will definitely be getting a UA on this patient. Then leads to heart failure and protein losing enteropathy. Sure, heart failure can have, especially if it's HFrEF, can lead to a low blood pressure and can have this appearance. But the one thing that makes me pause is how do we connect the heart failure with the diarrhea? Um, and I think connecting those dots and using the exam where there's diffuse pain to palpation, probably from the distension. I think this is losing the albumin through the diarrhea that's causing a decreased oncotic pressure and causing this patient to be anasarchic. Now, here's the thing: protein-moving enteropathy is not like a full diagnosis. It's usually caused by a secondary entity. And there's a whole list of things that can cause it: amyloidosis, lymphomas, Whipple's disease, lupus, even malignancies. You can also have sarcoidosis, TB, the list goes on. So even if this is concerning for protein losing enteropathy, the question then becomes, why is the patient having protein losing enteropathy? So I feel like that's where I'm kind of sitting at right now. I think the blood work and basic basic blood work would really help hone in the further information, and I'd be very curious to see a UA on this patient.
That's
Armin?
beautiful. The one thing on the exam that I don't know what to do, I'm curious what your thoughts are the mobile like a mobile abdominal mass, was it, Kiara?
Actually, it was non-mobile.
Non-mobile, like a non-mobile abdominal mass that was palpated.
Do you know where that was palpated, Kira?
It was towards the epigastric area.
Okay, so that, Charmaine, would make me more concerned for a lymphoproliferative process and either a stomach gastroadenocarcinoma. So yeah, thanks for pointing that out. But yeah, that I would definitely be concerned for a malignancy, especially with the weight loss and the cachectic appearance of this individual.
Yeah, yeah. No, I agree with you. I think, like, especially with that degree of weight loss, the question is, like, as you mentioned, are we dealing with the underlying malignancy and we're seeing complications of that? And whether that is low albumin or, sometimes bulky lymphadenopathy can really have Sorry, I forgot my English for like a few seconds. That can cause pressure and lead to like bilateral lower extremity edema and the vessels, like the compression. That's the word I was looking for, team. Like a compressive nature of masses as well. So yeah, definitely curious to see where the workup led you, Kiara.
I always forget my words in English and then I have to replace it in Spanish and nobody understands me. So that's horrible.
I
Yeah.
see you, my friend. I totally get that.
Yeah. Okay, I will continue. So for the third aliquot, I'll just mention some notable labs. So the CBC was basically normal, but during his hospitalization course, his platelets start decreasing from 158 to 56. Like no 156, like 56 total. Otherwise, his BMP remained basically in the normal limits. Um, his total bilirubin and direct bili were also normal. Total protein 7.2. Albumin was 1.6. AST initially 108, but then 550. ALT initially 23 and then 97. Alphos 411. It kept in that range. Lipase 7. Um, PT 16.4 and later 21. INR 1.4 and later 1.9. PTT 31. LDH 1800. Also, his ProBNP, I don't know his baseline, but it went from 642 to 2,500 later. He had a negative hepatitis panel, HIV, CEA, and AFP. We obtained a urine analysis, which was initially clear. He had just 1 plus protein. He had 4 plus urobilinogen. WBCs were 4 and RBCs 8. And there was some trace bacteria, but nothing very notable. His procal was 0.42. Later, it went up to 12. Lactate 1.8. Fibrinogen 600. I think I can tell a paracentesis results for now, or you want me to stop?
I think it's a good place to reflect on these labs,
Okay.
and then we can get some more. Um, Go ahead, Jazz. Floor is yours, my friend.
Oh man, I feel like where do I begin? I feel like this patient's like initial workup, there's so many, like I feel like this, Mariana's like trying to frantically highlight everything in red just because there's just so much to chew. So I feel like I just want to just full out and say that it is overwhelming seeing all this amount of data come in at this type of degree. And I have a feeling, you know, if we put too much emphasis on one, we will probably be led astray. I think the biggest picture here that I can take away is that this patient is very ill, and there is definitely a process that is going on in a systemic fashion. Because I'm trying to see how we can connect a very high LDH, thrombocytopenia, raised LFTs, and then an elevated BNP. So does that mean the patient has a liver and heart and potential protein-losing enteropathy, or is there a more systemic thing that can connect the features together? I think the biggest part that I felt like was interesting was patient's hemoglobin was normal, especially with how abnormal the rest of the labs were. But with that high degree of LDH, I think malignancy has to be on my mind, specifically either aggressive solid malignancy or a lymphoproliferative disease like lymphoma. Large B cell lymphoma can lead to LFT pattern, a high LDH, and in turn can lead to protein losing enteropathy as a secondary mechanism, if that is the case. However, the chronic diarrhea could have just been from like gastric adenocarcinoma or like other invasive disease of the intestinal mucosa. So I think right now, it's hard to tease apart what is true signal and what's noise, but these labs tell me that this patient is going is severely ill, and there's definitely a progressive, likely malignant etiology for his symptoms. Before I pass it over to Sharmin, the low albumin needs to be explained, and one can say it could be a negative acute phase reactant. However, it's too low for me to just attribute to that. So I think the diarrhea is the source of the loss of albumin because there's no evidence of significant proteinuria on the UA. However, UA can miss other types of protein, so I would want to get a protein to creatinine ratio. I think with the elevated pro-MBP, this individual is fluid overloaded and probably stressing the heart. And I would want to get a CT scan of the abdomen and pelvis to see what this mass on physical exam, where is it coming from? Is it more lymph node or is it coming from the gastric mucosa? Jeremy?
Beautiful. I'm very sad for this patient. There's a lot going on, and I totally agree with you, Jess. It's quite overwhelming. But I love how you were thinking through that to think about like, okay, what is the common thread? We have volume overload and we have like sick with elevated LDH. I do agree with you that like, it kind of smells like a lymphoproliferative disorder. Um, and I think with that elevated LDH, thinking about what causes that elevated LDH, like it's high enough that invokes like HLH or like lymphoproliferative disorders. The other causes like hemolysis is less likely, rhabdo infections are probably less likely as well. So you really, really think about the malignancy in that cause. And if you want to look at it from another lens would be the low albumin and the protein losing enteropathy, which is probably the likelihood. And whenever I think about protein losing enteropathies, thinking about if it's a luminal cause, like IBD, for example, or whether it's like secondary to a systemic disease that is like more affecting the lymphatics. And one way that you can hook in the heart is that constrictive pericarditis of some sort, really bad heart failure can lead to that. However, I agree with you that doesn't explain the rest of the picture, but I'm never opposed to an echocardiogram. It's always good to have that data. But I think, especially with the mobile mass, with what we're seeing, like a CT abdomen pelvis would also be with contrast would be my choice. And the other question is like whether a colonoscopy in this patient would that's another thing to consider if after the CT abdomen pelvis, because I suspect the tissue will be the issue, and depending on what that lights up, if there's anything in this abdomen, like abdominal cavity, or there is some more data to be gathered within the within the GI tract itself. But yeah, I agree with you. That low albumin seems to be kind of like the center. And 1+ protein, I loved your idea of like getting the protein to creatinine ratio, and the UA is like something to trend as well. Again, I agree, it's less likely to be nephrotic syndrome, but like the number of times I've been humbled by amyloidosis, many times, and tends to be infiltrated, tends to affect multiple organs, system. So yeah, I'm curious to see what you all did. Kara, any other thoughts from you, Jazz, before we give the mic back?
No, I think that was excellent. I'm not able to, for whatever reason, I'm having struggle making people co-host. If you can make Kiara co-host.
Yeah,
Thanks,
I just did. Thank you.
I'm already co-host. Okay, so I will first tell about the paracentesis and then the CT abdomen. So first we perform the CT abdomen, but I will just tell the paracentesis first. So it showed like 5.8 liters. Albumin, fluid albumin was 0.8, protein was 2.2, the cell counts was 100, neutrophils were 25%, and lymphocytes 53%, and acidic fluid cultures were negative. The serum albumin by that time was 2, so the calculated SAG was 1.2. So later, we also obtained an echocardiogram, which showed EF in 60%, normal systolic function, no effusion, and trace TR and PR. I will share the CT abdomen right now. Let me continue. Can you see it? Yes. Okay, I will start. Yeah. Would you like me to repeat it or just tell you the findings?
I think that was pretty evident, Kiara. We can go get the findings.
Yeah, okay. So the CT basically showed severely atrophic pancreas, multiple thick, small, and large bowel loops, speculated calcified mass in the central mesentery, measuring 5.1 centimeters, and multiple liver, cystic, and solid lesions, which were thought to be like Mets.
Oh, right. Um, phew, quite unfortunate for this patient, and it's also kind of remarkable when when you hear that history from the get-go, with that degree of weight loss, that degree of symptoms, that immediately we were worried about something very sinister. And fortunately, we are starting to find it. I'm going to just comment on like maybe the ascites fluid and then pass the mic. And as we go back and forth about the liver masses together. Um, in terms of like the SAG being 1.2 in general, I think there's just like such low albumin in the blood to begin with. So that would cause like more fluid to go into the ascites. So I would be, uh, and whether it's like evidence of portal hypertension, not portal hypertension, this is the patient that I would just be more cued in for other etiologies, and that it seems like is a complication of the underlying low albumin in my mind. So in terms of like, I'm glad it was like some for cultures, and like cytology would be another thing to think about, but it's not surprising to me that this patient has the degree of ascites just because the pure nature of the serum albumin being so low. And yeah, Jess, what are your thoughts on the liver masses? And we can go back and forth.
Yeah, very unfortunate case. So I think the first thing that caught my eye was the speculated calcified mass in the central mesentery. That's pretty sizable with 5.1 centimeters. And then the liver was probably the most striking finding when we saw on the CT scan. Numerous, like almost impossible to count lesions on the liver, which is very concerning for metastatic disease. I think common things being common, and Sharmin, this is where I feel like we'll need your help, but common things being common, I think you have to kind of rule out gastric adenocarcinoma, like a gastric mass. But with this diarrhea that's so profuse, if, could this be a neuroendocrine tumor that metastasized to the liver? That's one thing that I'm potentially thinking about. and then it could be gastric adenocarcinoma that's just spread to the liver. But from my understanding, I haven't seen gastric adenocarcinoma leading to cystic lesions in the liver like that, like cystic metastatic lesions. So then I also want to make sure I don't miss lymphoma here, or like not at least consider it. But the problem I'm having, like connecting those two, would be the spiculated mass. That makes me think it's more of a solid, but which makes me think of either gastric adenocarcinoma or carcinoid, is where I'm thinking at, especially with how many lesions there are in the liver. But what are you thinking, Charmaine?
No, I totally agree with you. So, I think the question for me is like, okay, are these two masses related? Are they separate from each other? Um, and where would be the biopsy the most helpful? Because oftentimes, if you think this is like metastatic liver lesions, the most common places that it comes from is like lung, is breast, is GI tract, right? And we're still like getting some signal from the GI tract in this case, like melanomas and neuroendocrine tumors, as you mentioned. So I think like that is where, if I had to like ground myself in like what is most common, those are the sources that I'm worried about. I do. Uh, and honestly, like I just don't have enough expertise to say like what that calcified mass is, or what does that represent, the fact that it has some calcifications to it, and the nature of the liver findings. So I think the next question I would ask is like, okay, do we biopsy both? Do we, or where do we go? Because the one thing I don't want to miss is like two different processes at play, and I agree with you that like with that elevated LDH and everything, I'm worried about a lymphoproliferative disorder as well. The other things like primary like HCCs also can do whatever they want to do. Although, like again, I don't think of cystic lesions, but I think this is where I would go down to radiology and talk to them and see what does it look like to you guys, and what do you want, where would be a good target to do next, because I don't know.
Yeah, I would definitely be talking to a radiologist for this and saying like, if but I think, yeah, I agree with you. I think I would be probably leaning more towards lymphoproliferative, just because how fast this is progressing, and also the number, the how many lesions there are in the liver. But I guess it's the biopsy would be the next step. Um,
Yeah,
yeah.
and yeah, I love all the chat and the tumor markers as well. I think it's worth sending the tumor markers while we are looking for biopsies. But again, tumor markers are not perfect. So yeah, I think tissue is the issue. All right, Kiara, what happened next?
Yeah, so I agree, tissue is the issue. So the the real story was that we reached out to IR, they performed a biopsy, but there was there were cystic lesions and solid lesions, but the biopsies they took came back for necrotic, a lot of necrotic tissue, so it was hard to evidence what was there. So they planned to perform another biopsy, but the patient was very weak. So when he was stable again, they took the biopsy. Meanwhile, we ordered some other markers. So CA, and AFP, all of these markers were negative. We also ordered chromogranin A, which came back very high in 1,153, 5-HIAA 260, and BIP was negative. So basically the hospitalization course was complicated by spontaneous bacterial peritonitis, very increasing LFTs due to mesenteric thrombosis, to and hepatic vein compression due to this mass, and multi-organ failure. So he was eventually discharged to hospice, and sadly he passed. So we obtained the results later after, and I don't know if you want me to tell about the biopsy results, the final biopsy result, or you would like to share your thoughts before.
Yeah, we can. This is incredibly sad, and thank you so
Yeah.
much first, Kiara, before even going to the final diagnosis for sharing this case. And there's so much, no matter what the final diagnosis is so much for me to learn and reflect on this case. I really deeply appreciate you sharing this journey with us. And Jad, any thoughts or any reflections so far, or what are you the most concerned about at this point?
Yeah, first of all, I agree wholeheartedly what you said, sure. I mean, very sad case. But I think this goes to what we said last, Eloquat. I think this really heightens the concern for neuroendocrine tumor,
Mhm.
carcinoid, especially with the liver. Now, in retrospect, now that we know this information, I wonder if the trace tricuspid regurg was a clue
Mm.
of carcinoid into the heart. That's the only other additional thoughts I have. But Kira, I would love to learn from you and what happened with this case.
Yeah, so yeah, you are both very right. And this was a very sad case, and I learned a lot from this patient. So I appreciate that for learning from him. So the final diagnosis, we performed the second biopsy. So it showed a well-differentiated neuroendocrine tumor. It was grade 1, which means like slow progression. So I believe this was ongoing for a very long time. This biopsy expressed CKAE1, AE3. To be honest, I'm not very familiarized with this. Um, it also was positive for synaptophysin and chromogranin A, which are very common markers for neuroendocrine tumors. It was negative for CD56, and the Ki67 proliferation index was less than 1%, which also means that it was very slowly progressive. So the final diagnosis was well differentiated neuroendocrine tumor grade 1 and most likely carcinoid syndrome due to the presence of the liver mets, the watery diarrhea, the 5H1, 5HIAA, the abdominal cramping, flushing. Oh, I forgot to mention he had some flushing, he said, but that was very later on the description of his hospitalization course. I was like, hey, just in case, did you had these symptoms at all? And he said, yeah. I was like, oh my God. Okay. And he also had this increase in pro-BNP and TR. So most likely also carcinoid syndrome too.
Thank you so much, Kira, for sharing. And I'm just so sad that this has been going on for a long time. And I'm very sad for whatever that has kept him away from getting care and trying to get to the bottom of this sooner. And I'm grateful for all the teaching and all the learning that we get to do and learn from this patient. Incredible job presenting this case, Kiara. And Jazz, you brilliant discussion. Any thoughts, any reflections?
No, I feel like it's always an honor and this is the first time I've ever co-discussed with you, Sharmin. So I hope we get to do this more often. This was a blast.
I can't wait, my friend. I can't wait to learn from you. That was great. You, yeah, it was just amazing to see you pick up on all the salient features, thinking about neuroendocrine tumor as well. That was absolutely brilliant. I'm grateful for the opportunity to discuss with you. Thank you again, Kiara. Thanks everybody to the chat. And Vinny, we're ready for you.
So, about the teaching points, our patient first presented with abdominal pain and distension, and we have a wide variety of approach to abdominal pain. The first thing that we need to understand it is that the importance to rule out emergencies and the possibility to the patient to evaluate for a decompensation. So Jazz initiated the discussion talking about the approach of gas versus liquid versus solid issue, as in possible etiology. We also have the VIPO mnemonic as in another possibility of approach. And Charmin talked about the anatomical approach. Besides, in the chat, we had some mnemonic about possible distension that would involve flatus, fetus, fluid, and the fluid, big tumor. Now, another thing that we could see in our patient here is the pulse pressure, and we need to monitor about his vitals and to see if the pulse pressure would like increase and how it will behave. About the initial management, we can proceed with just initial labs, EKGs, and monitoring and telemetry and vital signs to see the disease course. And after we had the initial panorama, we can evaluate if the patient has any signs of volume overload in the physical exam and do a complete and third physical exam. So our patient revealed to have a bilateral temporal wasting. Afterwards, was revealed that he had flushing, tricuspid regurgitation. We need to see if there are some peritonitis signs, and this could suggest peritoneal carcinomatosis, signs of cirrhosis such as pulmonary erythema, jaundice. If the cardiac component is involved, and we can see if there is some jugular venous distension, and diarrhea played an important clue for us here. And we need to investigate the tempo if it is intermittent and chronic blood or mucus. And also our patient revealed to have a loose weight and cachexia, and this points towards a malignant etiology. We also discussed about protein losing enteropathy secondary to malignancy for any perineoplastic etiology versus disruption in the GI mucosa. Our patient also had a very low albumin, and this collaborates to the decreased oncotic pressure. About our differential diagnosis, we had nephrotic syndrome, and when we saw the high LDH, we thought about lymphoproliferative diseases versus solid malignancy. In the imaging, the CT revealed metastasis, and the biopsy finally revealed a neuroendocrine tumor from a carcinoid etiology. So that's all. Thank you, guys.
Vinny, those teaching points were absolutely fire. I was impressed of how well you retain all that information and put it down into writing. And Kiara, thank you again for such a fantastic case to learn from. And huge shout out to Mariana, who last minute stepped up for scribing. Really appreciate it. Have a great Wednesday, everyone. Take care. Bye.